The Miller-McIntyre Periodontal Prognostic Index Part 2, Clinical Application. Before viewing this video, look at Part 1, the development and background of how this was developed, and that will answer many questions that may arise if you just watch this video first. There's 7 factors that compose the MMPPI, which is a shortened form of the Miller-McIntyre Periodontal Prognostic Index, which brands this and is simpler to use. The 7 factors that are evaluated are age, smoking, diabetes, molar type, probing depth, furcation, involvement, and mobility. Now, this can be done in 2 different fashions. First of all, this can be done entirely by the dentist, but let me show you how the dental assistant can be implemented in this and making the system so much shorter, briefer, and still be just as effective. These 3 factors, age, diabetes, and smoking, can be taken from the health history and can be filled out by the patient with the assistants helping them before the dentist actually sees the patient. Anytime a patient is over 40, we score a 1. Smoking, we score a 4, and diabetes, we score a 2. Let's look at patient number 1, and this is very typical of the patient that I saw in private practice. The age of the patient is 42, a 42-year-old male, and the patient is smoking a pack of cigarettes a day, and they are not diabetic. So before you actually start scoring the other factors, this patient is already scoring a 5. This is something that I hope will become commonplace in the future, and it is so much more descriptive, and that is a treatment-focused diagnosis, a TFD. We can say a patient has a gingivitis, it's localized, a periodontitis, and it's localized, and that tells you what the disease is, but that gives you no idea of how the case should be treated. But by modifying that somewhat and using a TFD, this should tell you exactly what the treatment is going to be. So look at the treatment-focused diagnosis on patient number 1. Moderate to severe localized periodontitis in the molar areas. So what does that tell us? Exactly where the periodontitis is. It does not mention that there's gingivitis in the anterior area. So other than the molar areas, the rest of the mouth probably could be treated by just a prophy. And in these areas with a moderate to severe periodontitis, as we will see, you're going to do initial preparation and root planing, and that may be the end of the treatment, or you may elect after doing your initial preparation that surgery would be indicated. So by having this particular amount of knowledge, moderate to severe localized periodontitis in the molar areas, you have focused on exactly where the treatment is going to be and probably what is going to be the treatment. All right, now let's look at the other 4 factors. We've already got age, smoking, and diabetes, and now the dentist comes in and does the probing depths, looks for furcations, and documents mobility. Now, how long does that take? That should be part of any periodontal exam, even a brief maintenance appointment. Those factors should be looked at. He then indicates to the dental assistant what tooth he would like or she would like to have scored, and in this case, we're going to score number 15. That's a molar type, which is type 2, because the maxillary second molar has the poorest prognosis of any molars. And if it were a maxillary first molar, we'd score that a 1. And we know that mandibular molars have a better prognosis than the maxillary molars. So in that case, we would score that a dash. The probing depths are 2. That means that there are at least 7 millimeter pockets and perhaps 8 millimeter pockets. And depending on the degree of inflammation, these pockets by root planing could be shrunk down to 5 and 6 millimeter pockets and then reevaluated to see if surgery would be indicated. There are 2 furcation involvements on this particular tooth, a mesial palatal and a distal palatal, and we are somewhat concerned about the mobility, so we place a 2 on that. So the score on this patient is a 13. If we go to the scoring percentages over there, you can see that these molars in this particular patient have, according to this, less than a 50% prognosis, and in all probability this patient should be referred to the periodontist. Now let's go ahead and give the patient a target to shoot for, and we will have a periodontal report card for them. And I think giving them this target is extremely important. This is what we're going to try to achieve. We're not going to be able to do anything about the age. The patient can stop smoking. They're not diabetic. We can do nothing about the molar type. We come down and we're not going to get an ideal periodontal depth from our initial preparation, but we're going to reduce that somewhat. The two furcations are going to remain, and we're going to decrease the mobility. So now we have a 7. So the patient goes basically from a hopeless prognosis to a prognosis of keeping the teeth for 15 years with treatment, 86%. That is extremely motivational to the patient if you will share that information with them. And as I said, this is very typical of the patient that I saw in private practice. Now let's look at patient 2. And this is a patient that probably would not get to the periodontist, but this is something that shows how impactful we can be with our periodontal treatment on lifestyle changes and actually becoming more of a physician of the mouth than just simply doing the mechanics of dentistry. This patient is a 29-year-old female, so she's under 30, so we place a dash. She's smoking 2 packs of cigarettes a day, and we place a 4. And she says she is not diabetic, so we put a dash. So at this point, from the health history, we've determined that this patient scores a 4. But let's look a little deeper. Her treatment-focused diagnosis is a generalized, very bleedy gingivitis with very enlarged tissues. So therefore, there's no attachment loss, and we look on x-rays and see that there's no bone loss. It is a gingivitis. In that situation, in all probability, this patient would not be referred to the periodontist, but this patient would be seen in the practice of the restorative dentist. But then we will look further on significant findings. Her mother and 3 aunts are diabetic. Now that raises a flag. This means there's a strong family history of diabetes, and it is gender related, which makes it even more significant. Then we see the patient is significantly overweight. At this point, you should be suspecting that this patient is diabetic, but the patient denies that she is diabetic. So what do you do in this situation? I would suggest that you do an in-office A1C. And an in-office A1C, if you buy it in packs of 20, it costs you about $12 to $13 to do it. And in her particular case, when you do the A1C, her A1C is an 8.7. Now this is extremely important, what I'm going to say now. We should never make a diagnosis of diabetes mellitus on a patient that has not been diagnosed by the physician. The reason for this, patients that are diabetic that are doing certain high-risk jobs like building skyscrapers and working on scaffoldings and all, if the employer finds out they're diabetic, it very well may cost their job. And so we don't want to get involved with this. So if the patient would consent to it by having an A1C done in the office and we come up with an 8.7, yes, we know the patient's diabetic, but you simply say your blood sugar is elevated. I think you need to see a physician to find out if you are diabetic. Now, if we don't do the A1C and the patient is a smoker, as we've already seen, and if we look at the A1C level, an 8.7, that scores a 3. Now we're working on the first molar, which provides 60% function, which is a very key tooth, and that scores a 1. Remember, on patient 1, we had a 2 because that was on the second molar. Probing depths are in the 5 millimeter range. Now let's think about this patient. This is extremely tender, bleeding, swollen gingiva. Are you going to go in there and probe 6 times on each tooth and make the patient uncomfortable? Yes, you can do that, but let me tell you what, that patient will never come back to see you. So what you want to do is to select an isolated tooth and very gingerly and tenderly feel around that tooth and sort of guesstimate at the probing depth on it. That's what we did on this patient, and the probing depth was a 5. But remember, this is a gingivitis that can be treated by scaling, good home care, controlling the smoking, controlling the diabetes, and stopping smoking. Are there any furcation involvements? Remember, this is a gingivitis, so there are no furcation involvements. Now, what do you note in the diabetic? Exaggerated mobility. Are we concerned about this? Obviously, yes. So we score that a 2. And we have a score of 11. Let's look to the right. A score of 11 is barely treatable, 53%, 50% chance of losing the teeth. But this is where you can have a marked impact. Let's now look and see what the target for this particular patient is, and we begin to have the periodontal report card that has been popularized by Dr. Bob Levine. Age remains the same, 29, 30. Patient stops smoking. Patient gets the A1C score down to about a 7.1. That gives us a score of a 1. The molar type remains the same. And certainly with 5mm pockets and no attachment loss in the gingivitis, you ought to get the probing depths down to 1 or 2 in an ideal situation. There are no furcation involvements. And are you going to improve the mobility by reducing the inflammation and controlling the diabetes? Yes. You're still going to be a little concerned about that, but look at this. The patient scores a 3. And what does a 3 tell us? The patient has a 96% chance of keeping the teeth. When at the initial exam, it appeared that this was basically a hopeless case. But can you see, as a dentist, being the physician of the mouth, how giving smoking cessation counseling, getting the patient in the hands of a physician to begin treating their diabetes and perhaps some weight loss, we can see how we can change the life of the patient. And just as an aside, an overweight 29-year-old female with stinky breath and bleeding gums, I doubt if she's in a relationship, and if she is, she's not going to be there long. So you can go in here and make marked changes in this patient's life, but by using the MMPPI, we can see how this can be used to motivate the patient. Now let's look at patient 3, a patient who is going to be much more difficult to motivate. And let's see why. We're dealing with a 75-year-old male who doesn't smoke and is diabetic, but does not know his A1C score and refuses to have the A1C score done in your office. Now, we're dealing with someone who's going to be a little difficult to work with. So what do? And we're going to score, then we're going to use arbitrarily a score of 2 until we can get a true A1C score. The TFD is a moderate to severe generalized periodontitis. So we're dealing with a patient that really needs some in-depth treatment, but it's going to be difficult to motivate. And let's see why he's going to be difficult to motivate. We put down the 1 for age on number 14. Patient doesn't smoke. We're going to put a 2 down because we do not know the A1C score. First molar, tooth that is used 60% function. We're going to go put a 1 on that. The probing depths are generally in the 8mm range, so we put a 2 there. And this particular tooth unexpectedly had only 1 furcation involvement. And the teeth are mobile, but at age 75, we're not as concerned about mobility as we would be in a younger patient. So this patient scores an 8, and this is where the rub comes and the problem comes. Because if the patient scores an 8, they got an 81% chance of keeping the teeth for 15 years. So how do you convince a 75-year-old who has a chance of keeping the teeth for 15 years, 80%, how do you convince them to have treatment? Now, this is an ideal case that can be treated by the dental laser because it's painless and does produce a good result. Now, what is the target that we're going to aim for this patient? All right, age remains the same, smoking, diabetes. We now do an A1C score and find out that the A1C score on this patient is a 7.1. Well, that's not as bad as we thought, so therefore we can lower the diabetes score to a 1. Molar type remains the same, and by just doing initial preparation, we can possibly get these probing depths down to the 5 to 7 millimeter range, and this is very important. What is a periodontal pocket and what is a periodontal defect? And if we go in and reduce the pocket depth and we reduce the inflammation and we don't get bleeding on probing, do we have active disease or is this just a periodontal defect? I submit to you we need to begin thinking of the term periodontal defect. And this is something that after treatment remains stable for many, many years without any particular bleeding on probing. We see crestal density forming on x-rays, and there is no increased probing depth. So I think this is an area that we need to think in terms of in the future, not considering depth alone, but the quality of the depth, thinking in terms of what is a periodontitis and a periodontal pocket, and what is a periodontal defect. We're going to get the probing depths down to 1, the furcation is going to remain the same, and we get the place we're really not concerned about mobility. So, using non-surgical treatment, we can get this patient easily down to a 5, increasing this from 81 to 93%. But the motivation comes not only in getting the mouth healthier, but having the patient learn to clean their tongue, letting them have a healthy mouth, less malodor, so forth and so on. So many of the videos on this you can refer back to and treat this patient in a better fashion, mainly by motivating him to do that. Now, what are the objectives of the clinical application? First, to motivate the patient to accept and complete treatment. Second, to create patient referrals. When you treat these patients this way and communicate with them and provide this information, and they go out and tell their friends this, are they not going to suggest, especially if you're a general dentist, you need to go see my dentist? It's amazing what he or she told me. Another objective is to simplify the scoring so that it requires no time from the dentist. And I think you've seen this, how we score age, smoking, and diabetes. And this is scored before the dentist even comes in. The dentist comes in, probes, gets probing depths, mobility, and then indicates to the dental assistant score 30, score 15, and explain to the patient what this means. Now, one of the objectives, if you're going to do that, is to train the staff to do the scoring. And the way you do that is simply to have a staff meeting, sit down, go to pdmillerswebtextbook.com, pull up this presentation, and go ahead and learn how to do this. But before doing it, everybody ought to look at the background and development of this technique so that they can answer patients' questions when they come up. The importance of smoking cessation. When the patient sees that smoking, the smoking score is so large, this is a powerful tool to convince them to stop smoking. Because as you will see in the smoking video, how the patient reacts when they're told that they have a 243% greater chance of losing their teeth compared to a patient who is a non-smoker with the same level of disease. And just as I've already said, patients who smoke have an increased chance of losing their teeth to periodontal disease by 246%. Ladies and gentlemen, that is a powerful tool. But here comes what the problem is. We have office overhead and we get paid for doing procedures. We do not get paid for any counseling time that we spend, perhaps like the physician. So therefore, for smoking counseling, have the patient call 1-800-QUIT-NOW, where they can get counseling on smoking 24/7, 365 days a year. But you, by mentioning this, the 246%, you have teed it up, and perhaps smoking counseling by 1-800-QUIT-NOW can be very impactful. So this is the tape that you want to look at on that smoking cessation counseling, which I think takes about 7 or 8 minutes. Now here's a question that goes through the head of every dentist scoring this way. Is the patient guaranteed this level of success? I'm hesitant to tell a patient that they've got a 96% chance of keeping their teeth 15 years when they have significant periodontal disease. So here's the answer. This is not a promise of success, but guidelines that allow the patient to succeed. And the patient assumes 100% of the responsibility for success, because let's look at the keys to his success. First of all, they have to brush, floss, or do interdental cleaning on a daily basis, and very importantly, clean the tongue. And there's a video on here on the importance of that, because even if you have a patient that brushes and flosses very, very well, after those bacteria have been removed, 90% of the rest of the bacteria are on the posterior third of the tongue, which you cannot brush off, and you have to use some type of metal instrument to scrape this off. And these bacteria in that area are sulfur-forming bacteria, so therefore malodor, halitosis, bad breath are associated not with the bacteria between the teeth, but on the posterior part of the tongue. Obviously, they've got to complete the selected treatment, and when I say selected, that is selected by the patient after they're given treatment options, and it's their responsibility to complete treatment. They have to be in maintenance, and they have to do maintenance on the recommended schedule basis that we recommend. We would like to see them stop smoking or at least cut back. Diabetic patients are encouraged to control their blood sugar. Now look at that. All of these factors, as we have said above, are under the 100% control of the patient. So if they don't follow through, then you're not going to have the success rate that they were told they're going to have. But whose fault is it? It's a patient's fault. So the important thing here is for you as the dentist to understand that you are not guaranteeing anything, but you are guaranteeing that if they do the things they're supposed to do, they're going to have a much healthier mouth. And as I said earlier, the dentist assumes no responsibility for the outcome. It is entirely under the control of the patient. I mentioned 2 videos that you may want to look up. One is the importance of cleaning the tongue, and you can see the metal instrument that I personally use in my mouth. And also there's a video on here that leads the least expensive, most effective mouthwash. I would suggest that you look at both of those. You can have a positive impact on the staff by doing this. And let me tell you how that is done. The assistants and the hygienists become a more integral part of the team. Number 2, by doing that, this adds prestige to their job description, which certainly does increase morale. Third, they become a more important person in the eyes of the patient. Because they are more important in the eyes of the patient, this enables them to better answer questions that the patient has without taking your time to answer many of these questions. There are also additional positives. I think this fulfills a moral and ethical responsibility in treatment planning. So often the dentist tells the patient what they need and assumes all the liability, rather than offering treatment options and letting the patient select the one that suits their situation best. In the future, I think we're going to be required to provide these treatment options and the motivation of the patient can markedly be impacted, as we said, by using the MMPPI. Conclusion. Scoring markedly motivates the patient to accept treatment and to complete treatment. It's fast, simple, and easy to do, especially if you have a well-trained staff. Third, by providing patients information and giving their score sheet to take with them that they can show to other people, and giving some blank sheets that they can pass out, this is going to increase referrals. It proves unequivocally that many teeth that were initially thought to be hopeless are in fact treatable, and it also proves that teeth with furcation involvement can have a much better prognosis than we had previously thought.